hear me?
Yeah, perfect. There we go.
Okay, I'm sorry for that delay. But good morning to everyone, and thank you for the invitation to present on this topic. So Amy asked me to do a presentation, and she suggested that the defensible approach is a good aspect to always include in this meeting, because there are a lot of people who are on this meeting who are very worried about being sued in obstetrics and gynecology. So let me just start with a few general comments about that. Just trying to take away this bar at the top of my screen. But anyway, the question is, how do we avoid medical legal threats? And the simple answer is, we can't. Unless maybe you choose a low-risk specialty, move to something like microbiology or maybe pathology, where the patient, when they're referred to you, might already be dead. But in our specialty, if any patient you have previously managed, or any patient you have previously managed, is a potential source of a medical legal case. But we can minimize the risk if we comply with ethical and professional standards. And professional standards include keeping up to date with the latest scientific research findings and knowledge in your field. Because what is regarded as appropriate care changes as knowledge expands. So in order to stay out of trouble, you need to communicate well with patients, their families, and your colleagues, write clear and comprehensive notes, use a chaperone for intimate examination, and consult when you're out of your depth. And if the patient is not satisfied, get a second opinion. You must be aware of local protocols and only diverge from them if you have a strong basis to do so. And that will especially be the case if, since the protocol was written, there's new evidence which suggests a different approach is required. So the problem of PPH, how big is it? Well, it's very big. Out of 260,000 maternal deaths in 2023 worldwide, 27% were estimated to be due to obstetric hemorrhage, and that remains the most common cause of maternal death worldwide. It's estimated that one woman dies from postpartum hemorrhage every 7 minutes. Probably someone has died since I started this talk. But it's not just about deaths. For every maternal death from PPH, there are many more cases of women who suffer severe morbidity due to PPH. We could call these near-miss cases. And that might include the need to be in ICU, to receive massive transfusions. It includes cases which end up requiring hysterectomy. And it's increasingly being recognized that women who have suffered severe PPH have a high risk of having post-traumatic stress disorder. I think it would be of interest to just say that the case fatality rate from PPH at cesarean section is approximately double the case fatality rate for PPH after vaginal delivery. So if you do get a PPH at Caesar, it's more likely to lead to death than after vaginal delivery. If we move more locally to South Africa, and this is the latest data from the 2023 Saving Mothers report, obstetric hemorrhage doesn't actually stand out clearly above other causes. It's one of 4 main causes of maternal death in South Africa. The others being non-pregnancy related infections, medical and surgical disorders, hypertensive disorders. So each of these 4 contributes about 16 to 17% of the maternal deaths in South Africa. But if we look at which deaths are actually avoidable within the healthcare system, then it's a slightly different picture. So this is data again from Saving Mothers 2023. So every maternal death that's notified is assessed by expert assessors. And one of the things the assessors have to do is to categorize the death into one of 4 categories relating to avoidability of the death within the health system. So the first category is there was no suboptimal care. So that case was unavoidable, or the death was unavoidable. Then you have a second category, suboptimal care, but even if care had been better, it wouldn't have changed the outcome. So that's also an unavoidable maternal death. Then we get our two categories of possibly or probably avoidable maternal deaths. So if we look at the graph at the bottom, along the bottom, we've got all the different causes of maternal deaths, and then the bars are showing the actual numbers of maternal deaths. So for each cause, we've got these 4 avoidability categories. And I want you to focus on the yellow bars, because these are the number of deaths which were clearly avoidable. And here, if we look at that, there is one cause of death where the clearly avoidable deaths are far more in number than any other cause, and that is obstetric hemorrhage. So that's very important, because it tells us that if we can focus on obstetric hemorrhage, we have the biggest, it has the biggest potential for reducing the numbers of maternal deaths. This is also, this is data from the Saving Mothers 2020 to 2022 triennial report. And what I want to point out here is that it's got all the causes of maternal deaths on the left, but on the top here, it's got the different levels of care where the patient died. And because there's a lot of people joining this webinar who are working in private hospitals, who are running private practices, let's look at the column for private hospital. So the point I want to emphasize here, well, the most deaths were in the non-pregnancy related infections category, and that's because this is 2020 to 2022. So it includes the time when we were affected by the COVID pandemic. So by far the most deaths were due to COVID during that period. But putting that aside, because that was a sort of, well, we hope it was a one-off situation in that triennium, we can see that the cause which results in the most deaths in private hospitals is obstetric hemorrhage. And that is a consistent finding. Although the numbers are small in 1 year in 2023, it was also the most common cause in 2023 of maternal death in private hospitals. So 36 women died in private hospitals 2020 to 2022 due to obstetric hemorrhage. I'm assuming then that most of these cases were deaths that related to bleeding at cesarean section, because I think, as we've just seen, most of the deliveries are done by cesarean section in private. So whether it's a world view, whether it's a South African view, whether it's private hospitals in South Africa, for everyone, obstetric hemorrhage, I think, is a priority to be looked at. So I think the first topic that I was asked to talk on by Amy was preventing PPH, the defensible approach. But basically, I don't think there's much to this topic. So I'm just going to address it very briefly. The simple guideline here is that all women, immediately post-delivery of the baby, or babies, if there's 2, should receive, and this is according to WHO guidelines, either oxytocin, 10 units, which can be IM or IV, or carbetocin, which can be IM or IV. With the national maternity care guidelines used in the state sector, it doesn't include carbetocin, it just recommends oxytocin. And that's really a cost issue. There are advantages to carbetocin because it's heat stable and it has a longer half-life, especially compared to intravenous oxytocin. So, but either of these two are effective in reducing PPH and are recommended by international and national guidelines. So in terms of the defensible approach, I think this is not a difficult area because no one can predict with certainty which woman will have a postpartum hemorrhage. And there is no treatment or management that can guarantee to prevent a postpartum hemorrhage. So as long as the woman receives prophylactic oxytocin or carbetocin, I don't think there's any way that you could be successfully sued for a postpartum hemorrhage having occurred. So it's a simple guideline, which I think is routinely followed, and I don't think there are any issues with that. Just one extra point I will make, because I think some people have been using tranexamic acid, and that's also referred to as cyclocapron sometimes, as prophylaxis, maybe at Caesar or even at vaginal delivery. And I want to emphasize there's no evidence to support that practice, and it's not recommended. There has been quite a bit of research done on it, and so far, the research has shown that it doesn't help prophylaxis against PPH. And so it shouldn't be used because it can also have adverse effects. So now let's move on to the main topic, which was preventing near miss or mortality from PPH, the defensible approach. So here, the situation we're dealing with is a patient who delivers either by normal delivery or vaginal delivery or cesarean section under your care in a health facility, and then she's up with a PPH. I think here there are several outcomes where you might be at risk of being successfully sued if those outcomes unfortunately occur. And I'll mention two of those. Obviously, maternal death. If the woman dies, she delivered under your care in a health facility and she ends up dying, then that would certainly be a situation where the relatives might end up suing you and they might be successful. And the other one, which is worth mentioning, is if you end up doing an emergency hysterectomy, the patient survives, but then she may come back to you and sue you because you did the hysterectomy and she's lost her fertility. Maybe she doesn't have a live child. Maybe it was a situation of an abruptio or a preterm baby, and the baby didn't survive either. Now you've taken away her fertility. Maybe there'll be a litigation in that regard. And as the gynecologist, you'll probably feel quite indignant if that were to happen. And your views would be, well, I saved your life. I did what I had to do in the circumstances. How can you sue me in that situation? But maybe we need to look at that a little bit more carefully, because I think there certainly have been situations where a specialist has gone very quickly to the option of hysterectomy. Specialists are trained in hysterectomy and they're skilled in hysterectomy. Therefore, they often resort to that option because they can. And obviously, if it's done successfully, it's a definitive way to stop the obstetric or the PPH. But maybe there are other issues to consider. Could the hysterectomy have been avoided? For example, were there delays in diagnosis of the PPH? Or after diagnosis of the PPH, were there delays in initiating evidence-based treatment for PPH? Or was there an inappropriate first response when the PPH was diagnosed? And maybe if these are valid considerations and the patient deteriorated to a situation where the only way to salvage the situation was to do a hysterectomy, then there could still be a basis for litigation. So litigation may be successful if you fail to manage the PPH according to the latest current national or international recommendations. So it's very important to be up to date with those recommendations. As long as you followed them, then you're on solid ground. Now, because this is a SASOG meeting, I actually looked at the SASOG guidelines, the Better OBS guidelines. And there's a recent edition of the African Journal of Obstetrics and Gynecology, 2025, Volume 3, Issue 1, which was recently published. And it's got various articles from the Saving Mothers report in there about different causes of maternal death. But at the end of that edition of the journal, it has the latest version of the Better OBS PPH guideline. It's called PPH 3.0. I presume it's the third version. And I'm just quoting here from that guideline. It says, these guidelines were drafted by a clinical team from Mediclinic and were reviewed by a panel of experts from SASOG and the Better OBS clinical team in 2019 and revised by the Scientific Committee of Better OBS in 2023. All attempts were made to ensure that the guideline provided is clinically safe, locally relevant, and in line with current global and South African best practice. So I mean, it's great that there's such a guideline. I think it's great that there are better OBS guidelines. It's a great initiative. And obviously, if the gynecologist followed what was recommended in this guideline, and then there was litigation about the outcome, they would be on, I think, on solid ground if they could refer to the guideline and say, this is what I did, and it's in keeping with what is recommended. It's also quoted that it says in the guideline, succinctness was considered more important than comprehensiveness, and I think that's great. It is a very succinct guideline, quite short, easy to read, and I think that's the way to go. The guideline also says, all guidelines must be used in conjunction with clinical evaluation and judgment. Care must be individualized when appropriate. The writing team, reviewers, and SASOG do not accept accountability for any untoward clinical, financial, or other outcome related to the use of these documents. So I think what they're saying is, if the document goes out of date and you still use that document and you get litigated, don't blame SASOG if it proves to be a problem in the case. So you still have responsibility for keeping up yourself with the latest international knowledge and evidence. The guideline finishes by saying comments are welcome and will be used at the time of the next review. So let's make some comments. In the preamble to the guideline, it has this quote. And I think this, it's mentioned that the guideline was updated in 2023. 2023 was the year when the emotive trial came out. And let me say at this point that I think the emotive trial and the emotive approach to managing labor is probably the big new thing in PPH management. So it does refer to it, and they say accuracy of the amount of PPH can be improved with the use of the maternal well tray or calibrated drapes, and outcomes can be improved with the implementation of the emotive bundled approach. And they refer to an algorithm at the end of the guideline where the emotive bundle is incorporated. My comment here is that this statement doesn't actually quite capture what the key principles of the emotive approach are, and I will go through those. Also, in the main text of the guideline, where it gives detail on how to manage a PPH, it doesn't actually incorporate the principles of emotive. The principles in this guideline with regard to management that it focuses on are these. Firstly, resuscitate. And here it goes full out on resuscitation. Call the most senior midwife, inform the obstetrician, call emergency center doctor if obstetrician is not on site, give oxygen, put up 2 large bore IV lines, run in 2 to 3 liters of crystalloid fluid or 1 to 2 liters of colloids, take blood for cross-match, order 2 units of packed red cells and 2 units of FFP, give tranexamic acid 1 gram. So that's the first sort of principle, aggressive resuscitation. And the second principle is establish and treat the cause of the postpartum hemorrhage according to the 4 T's, the tone, the tissue, trauma, and clotting, the thrombin or whatever. So those are really the principles that the Better OBS PPH guideline relies on. And what I'm going to just show is that I think we need to have a slightly different approach to what principles we have with regard to management of PPH. So firstly, let's deal with definitions of PPH and diagnosis. I think as a general definition, we can agree that PPH is excessive blood loss following delivery of the baby. But what actually is excessive when we talk about blood loss? I think, again, we'll probably all agree that any amount of blood loss that results in hemodynamic compromise would be excessive. But by the time a woman displays signs of hemodynamic compromise, that's very late in the PPH process. she's probably lost well over 1,000 mils and maybe closer to 2 liters by the time that happens. And really, we need to be diagnosing PPH much earlier than that so we can intervene and hopefully prevent the mother from ever reaching that stage where she's becoming compromised. So we also, apart from the sort of vital signs definition, we also need to have a definition with regard to the amount of bleeding in mils. So what cutoff for defining PPH should we use? Well, in order to define PPH in terms of volume of blood loss, we first need to know what is the normal volume of blood loss after delivery. And if you ask people who are doing deliveries day in and day out, they might not know the answer to that question. They'll write on the maternity case record, blood loss plus minus 250 mils or 200 mils. Not that they've actually measured it. It's just what they assume is normal. But actually, we have very good evidence about what is normal blood loss after vaginal delivery. In particular from the emotive trial, because in the emotive trial, blood loss was objectively measured, collected by research workers and measured for more than 200,000 women who delivered vaginally. So we actually know very well what is normal with regard to vaginal delivery. Here I'm talking about vaginal delivery in a health facility where active management of labor using oxytocin or carbetocin has been used. So what I can tell you is that the average blood loss, the mean blood loss, is 350 mils after normal delivery. However, looking at the mean blood loss is probably not a good way of saying what is normal blood loss. Because remember, a small minority of women may bleed a very large amount, maybe 3 liters, 4 liters, etc. And those cases are going to drag the average up. So it doesn't really reflect what is normal. So probably a much better way of looking at the blood loss is to look at the median blood loss. So the median blood loss is that volume of blood loss where 50% of women bled less than that and 50% of women bled more than that. And the median blood loss after vaginal delivery is 200 mils with an interquartile range of 120 to 380. So I think if you always assume that 200 mils was the normal blood loss after a vaginal delivery, well, that is actually correct. We have good evidence of that. And what this means is that the traditional definition of a PPH being 500 mils looks like it's actually appropriate because it's obviously more than normal. And also there is evidence to show that above 500 mils, bleeding above 500 mils is associated with adverse outcomes compared to bleeding below 500 mils. So that's with vaginal delivery. What about cesarean section? We have much less evidence on what is normal at cesarean section, because I suppose it depends a lot on the surgeon, how experienced the surgeon is, and also it's very difficult to measure blood loss at Caesar accurately because, well, for obvious reasons. Blood is in a lot of different compartments. It might have gone through the cervix to the vagina, might be soaked into the drapes and swabs, it's in the suction bottle, it's on the floor, etc. So we don't have the same quality of evidence to say what is actually normal at cesarean section. And obviously what is normal for one surgeon might be rather different from what is normal with another surgeon. But clearly, mean and median blood loss, we can assume are greater than with vaginal delivery. So probably because of that assumption, in Better Obs guideline, it actually says at the start that PPH is the loss of 500 mils or more of blood from the genital tract within 24 hours of birth, following normal delivery, but it's more than 1,000 mils following cesarean section. And that definition is quite a popular one in South Africa, I know that. But the WHO states clearly that PPH is 500 mils, irrespective of mode of delivery. I can point you to a recent article in the BMJ Open, where they had a group, quite a large group of obstetric or PPH experts from across different countries and continents, and they addressed the issue of bleeding at cesarean section. And there was a clear consensus that PPH at cesarean section should be regarded as 500 mils, as long as there's ongoing bleeding, in keeping with the WHO definition. And I think the principle here is that the issue is not whether it's Caesar or vaginal delivery. The issue is how much blood has the patient lost, because with certain levels of blood loss, there's an increased risk of adverse outcomes. So it doesn't really make sense to say PPH is a different volume depending on the mode of delivery. So I think that's one thing that maybe I would recommend. Let's stick with 500 mils for all. If we look at new interventions for postpartum hemorrhage that have been introduced to obstetrics, let's say over the past 30 years or so, there are some new drugs that have become commonly used, like misoprostol, heat-stable carbetocin, tranexamic acid. There are some new mechanical methods like balloon tamponade, non-pneumatic anti-shock garment. There's also a new thing which I think is going to become probably much more commonly used, which is a suction tamponade. From the surgical aspect, there are some new techniques that have been introduced into common practice, like stepwise devascularization of the uterus and the B-Lynch suture. But my comment on all these new things that have come in is that all of these are interventions to either prevent PPH or to treat PPH. None of them was designed to detect PPH earlier. And I think we need a new approach to detect PPH earlier, because despite all these interventions that have been introduced, PPH remains the most common cause of maternal death. And unfortunately, worldwide, the numbers have not decreased over the past few years. There may even be a small increase. So a new approach is required to detect PPH earlier so that management can be implemented at an earlier stage of the PPH. The current prevalent approach to PPH diagnosis based on visual assessment is very poor at detecting PPH. We know this from the emotive trial. This is a slide from the trial, and I don't have time to go into the details, but remember I said 200,000 plus women who delivered vaginally had their blood loss objectively measured by research workers in this trial, separate from the clinical workers who are managing the patients. So what was found was, before the emotive intervention, over half of all PPHs, blood loss of 500 mils or more, were actually never diagnosed as a PPH. And this trial had 4 countries: Nigeria, Kenya, Tanzania, and South Africa. And if I tell you that, maybe some of you will think, well, it's probably Nigeria, Kenya, where they couldn't diagnose PPH. I'm sure in South Africa, we could diagnose more than half of our PPHs. But that would be a wrong assumption. South Africa was far the worst country in terms of diagnosis of PPH. 73% of all PPHs were never recognized as being PPHs in South Africa. And many of these were actually PPHs which were severe, of 1,000 mils and more. So it really showed that our current standard practice for diagnosis of PPH at vaginal delivery just doesn't pick up most of the PPHs. And I'm sure the problem is even worse at cesarean section. So with our current practice, I will put it to you that you have not been diagnosing postpartum hemorrhage. You've only been diagnosing severe postpartum hemorrhage. And the management that we know and use for PPH, as presented in the Better OBS PPH guideline, that aggressive resuscitation and addressing the specific cause of the PPH, that is management that is actually tailored to deal with the severe PPH greater than 1,000 mils. Because the fact of the matter is, we tend not to actually recognize a PPH before 1,000 mils. And I'll also put it to you that you have not been providing any specific treatment to a PPH that reaches 500 mils at that level. So we need to improve detection of postpartum hemorrhage. If we treat the postpartum hemorrhage earlier, as soon as it reaches 500 mils, before there's any clinical signal that there's a problem, then we can prevent progress to a severe PPH and the increased risk of morbidity and mortality that comes with it. So that is exactly what the emotive trial was aiming to do. It aimed to assess a new multi-component clinical intervention for early detection and management of PPH after vaginal delivery. The primary outcome that was used to evaluate whether that intervention was effective or not was a composite of severe PPH, maternal death from PPH, or laparotomy and the need for laparotomy for bleeding. PPH was defined as bleeding of 500 mils, and severe PPH, which was in the primary outcome, as a bleeding of 1,000 mils plus. In terms of the actual intervention, there were two aspects. The first was every vaginal delivery in the intervention groups had objective measurement of post-delivery blood loss by the attending clinical staff, which would usually be a midwife, using a calibrated plastic drape. So this allowed early detection of PPH as soon as 500 mils blood loss threshold was reached. That was the E of emotive. And this meant that treatment for PPH could be initiated as soon as blood loss reached 500 mils, but also if there were other clinical signs, even if the blood loss hadn't reached 500 mils. The second part of the intervention was that a standardized first response treatment bundle was introduced for every case where PPH was diagnosed, and that bundle was called Motive. Importantly, all components of that first response could be administered by the midwife without needing a doctor's authorization or order, which meant that this whole intervention really empowered the midwife, firstly, to diagnose PPH confidently, and secondly, to manage the PPH with an initial first response without the need for backup from a doctor. We're not saying a doctor shouldn't be called or if the doctor was there, shouldn't get involved, but often it might take time to get in touch with the doctor or for a doctor to come after they've been contacted. So this would allow early intervention for PPH before problems arose. With regard to the actual first response, the standardized first response for any cause of PPH. So it's a bit of a different approach. It's not an approach of saying, try to find out what the cause is and then treat accordingly. It's saying, it's a PPH, do this as a first response, irrespective of what the cause is. So that first response is the Motive bundle. Motive stands for M, massage of the uterus. O, oxytocin. In South Africa, for the emotive trial, we use this specific protocol. There might have been a slightly different protocol in some of the other countries, but this was the protocol that we used. Oxytocin, 10 units IV in 200 mils of saline over 5 minutes. Then tranexamic acid, 1 gram in 200 mils, a separate 200 mil bag over 10 minutes. And then IV fluid. So as long as you've given the oxytocin and tranexamic acid in this way, you will have given a 400 mil bolus of crystalloid fluid over about 15 minutes. And that's a good initial fluid bolus. But following that, an IV 1 liter would be put up with approximately 20 units of oxytocin in it to run at a steady rate for ongoing oxytocin infusion. And then the E of Motive was examination. And specific points that were emphasized was to make sure the bladder wasn't full, to make sure the placenta had been delivered, and if it had been delivered, to check the placenta or recheck it to make sure that it's complete, to assess for any obvious vaginal or perineal tears, and to also look for any signs of a coagulation problem. All components of this bundle would be done as quickly as possible. It's not that one has to be specifically done after the other. Depending on how many people you can get to assist you with, then each person can be doing a different part of the bundle. Now, if bleeding persisted after the Motive bundle was implemented, or if there were signs of shock, then there would be a need to escalate to a higher level of expertise. So that was the emotive intervention, which was done in the emotive trial. So what were the results? So remember, the primary outcome was a severe postpartum hemorrhage of 1,000 mils or more, or the need for laparotomy or death due to bleeding. So there were about 80 hospitals in the trial, of which half were randomized to be control hospitals, where nothing was introduced in terms of a new intervention. They continued with their routine management of PPH, whatever they did. And then the other half of the hospitals were randomized to do the emotive intervention, which included a training period before the data collection started, where the midwives and doctors would be trained in the new protocol. So this slide shows the results. In the control group, there were about 50,000 vaginal deliveries. And the primary adverse outcome occurred in 2,139 cases, which was 4.3%. In the emotive intervention hospitals, there was also approximately 50,000 deliveries, and the primary outcome only occurred in 794 cases, 1.6%. So this ended up as a risk ratio of 0.4, which means that there was a 60% reduction in adverse outcomes related to postpartum hemorrhage, which is a huge decrease. And because of the large numbers in the trial, nobody can really question the value of this intervention in reducing adverse outcomes from PPH. So that trial was published in 2023. By the end of 2023, WHO had issued a recommendation on the assessment of postpartum blood loss and the use of a standardized bundle for postpartum hemorrhage. And so based on the trial, it's now standard practice, recommended practice, that all facilities should objectively measure blood loss after delivery, vaginal delivery, and where PPH has been diagnosed accordingly, there should be a standardized bundled approach to the first response to that PPH. The guideline also states that the same principle should be applied at cesarean section, although is not able to give the same detail about how that could be done, because obviously the emotive trial was only done for vaginal deliveries. So now the process is at a stage of implementation, worldwide scale up. In South Africa, we published this article giving some guidance on how emotive should be implemented. And in the Saving Mothers, which are the national recommendations from the Department of Health, it specified emotive approach for managing PPH with objective blood loss measurement using a calibrated drape or tray for early detection, and a standardized bundled approach for first response treatment must be scaled up nationally to all maternity healthcare facilities. So I just want to go over the new principles that we have learned from the emotive trial and which we need to introduce into our maternity care. The first principle is we must use objective measurement for postpartum blood loss. And then following on from that, we need to have clear thresholds for when we are going to intervene with regard to postpartum hemorrhage. And with the vaginal blood loss, it's straightforward, 500 mils. And when we do reach that threshold, the third principle is that we should have a standardized first response bundle, which can be routinely done, and it can be done by the attending person there in the labor ward. It doesn't require some specialist to give their input. So those are the principles. How do we implement emotive? It's not difficult to implement. I can say that from experience, but you do need equipment, and you need equipment to objectively measure the blood loss after vaginal deliveries. And there are two options. In the trial, they used disposable calibrated drapes. And we do have a company in South Africa who are making disposable calibrated plastic drapes. It's called the Elavi drape. You may have heard of the Elavi balloon, same company, Sinapi, who have now designed a drape that can be used for collecting blood loss after vaginal delivery. By the way, I just want to say, I've got no conflict of interest. I'm not representing any company. I've got no connection with these companies. The second option is a reusable plastic calibrated tray. There's one called the maternal well tray, also available in South Africa. These things are not expensive items. The drapes, my latest information was that they cost 1,400 Rand for a roll of 100 drapes. So 14 Rand per drape. So you need one drape for a delivery. And the trays, there are a few R100 for a tray, but it's a robust tray that can be cleaned, sterilized, and reused on numerous occasions. So all labor wards should have at least one or preferably both of these options available so that every vaginal delivery can have objective measurement of postpartum blood loss. That's a picture of the drape that was used in the emotive trial. It was called the brass V drape. You can see that it's wide at the top, so the woman can, buttocks can sort of sit or lie on that upper part, and any blood that she bleeds can then be channeled into the funnel, which can overhang the bed if she's on a bed. And at the bottom of that funnel, there are calibrations, a bit like a urine bag or something like that, where you can read off the amount of bleeding. But it's more accurate than a urine bag because it's narrow at the bottom. So that was what we used in the trial. It was made in India. The locally manufactured drape, it looks like this. It doesn't have a blue color, but it's got calibrations at the bottom, as you can see in that picture. With regard to the tray, this is what the latest version of the maternal well tray looks like. It's made of a robust plastic. It's got a Then you've got two wells for catching the blood. The first one next to the ramp would be the initial one where the bleeding would go into. And you can see here that the woman will rest on that ramp and the perineum will overhang that first well. If you look inside the well, you can see these two thick lines. The first thick line here represents 300 mils. So if the blood reaches that level, you know she's bled 300 mils. And the second one is the 500 mil mark, which will indicate PPH. In between, you've got some small notches. That one's 100 mil, that one's 200, that one's 400. So you can at least objectively say to the nearest 100 mils or maybe to the nearest 50 mils or so what the blood loss currently is. And this is the first well, the blood goes in here. Once it reaches the second line, which is 500 mils, if the woman bleeds more, and this is on a flat bed, then the blood will start to overflow to the second compartment. So if you're walking past a woman who's on one of these trays, as soon as you see the blood is entering the second compartment, you know straight away this is a postpartum hemorrhage. So there you go, the blood will go into the first compartment, and once it's reached 500, start to spill into the second. This is a picture of a PPH. You can see it's an obvious PPH. Blood has overflowed to the second, and there's also a lot of blood in those swabs. So this was a delivery done in the hospital by the midwife, and I was called immediately when the midwife recognized that the blood flow was exceeding 500 mils. And I think it was a case of a sort of combination of atonic uterus and bleeding from a tear. And we were able to deal with that promptly and without any complication to the mother. So if you want to implement emotive, you have to have that equipment, and you'll have to have champions who are going to push that we use it. In any labor wards, there should be a midwife who's a champion for the emotive, and there should also be in a hospital setting a doctor who's also going to champion it. We conducted training in KZN where I work for all districts, all facilities. It's a simple training. It took about 4 hours, and it was quite a thorough training because we were training champions. And then we expect the champions to go back and train everyone else. For each individual, it doesn't necessarily have to be as long as 4 hours. It's something you could understand after about 1 hour or so. The other useful thing is in a post-delivery observations chart, it's good to have a column which we can now have for actually documenting the amount of mils in blood loss, not just putting down heavy, pad soaked or whatever. We can actually write down the volume, and that will then alert the person doing the observations to need for action when it reaches 500 mils. Then I'm almost done now. What about the cesarean section? We need to implement the emotive principles to reduce excessive bleeding at cesarean section. Remember these principles. We need to have objective measurement of postpartum blood loss. I don't think we're doing that at cesarean section. The patient bleeds. There's no objective way during the operation, as the operation proceeds, that the amount of blood loss is being tracked. That means we don't have any specific threshold for when a special response as a PPH is required. And certainly we don't have a standardized first response bundle when we do recognize excessive bleeding, which might be required from the anesthetist or it might be required from the surgeon. Each person just does what they think is best, on an individualized basis. So how do we implement these principles to cesarean section? We need a new mechanism, or we need a mechanism to measure blood loss objectively in real time during the Caesar. We need a clear protocol on action to be taken when a specific blood loss threshold is reached. And this will need teamwork between the surgeon, the anesthetist, and the theatre nursing team. And we'll need champions from each category to implement the new protocol successfully. The protocol must cover, amongst others, these issues. How do we measure blood loss objectively at Caesar? Whose role is that measurement of blood loss? What threshold of blood loss should we choose for implementing specific responses for PPH? What actions should the anesthetist take when the specific threshold is reached? What actions should the surgeon take when the threshold is reached? And how do we actually implement the new protocol? Well, we've been working on this in KZN, and we've developed a protocol. And just to I don't have time to go through it, but just to say, how do we measure the blood loss objectively? The main method is through suction canister, which is calibrated. We have to take care to try to suction as much of the blood as possible into the suction canister and to exclude liquor from the calculation of the ongoing blood loss. Whose role is the measurement of blood loss? Because we're relying on the suction canister, the circulating nurse can check the suction canister reading, and the anesthetist can document the cumulative blood loss every 5 minutes, because they already do 5-minute assessments of BP, pulse, and so on. They can also write down what's the current blood loss. And what threshold of blood loss should we choose? We've said 500 mils in the suction canister, action must be taken, because we know that if there's 500 mils in the canister, there must be a lot more actual bleeding that's happened. And no one can argue that it's not an excessive blood loss. What actions should the anesthetist take? Well, we've said we should follow the same bundle that we use for vaginal delivery, which has been shown to be so successful with regard to the drugs and the IV fluids. What action should the surgeon take? This really depends on whether by the time the threshold is reached, the bleeding has stopped or whether it's still ongoing. But if the bleeding has reached the threshold and is still ongoing, then if there's senior help that's available, it should immediately be called at that stage. Meanwhile, the surgeon should apply pressure to the bleeding points to get control of hemorrhage rather than just keep trying with suturing in vain. If pressure can't control the bleeding, we can use a tourniquet to stop the bleeding. And this has often been seen as a last resort action. It doesn't have to be last resort. It can be done earlier in the process before the patient is compromised, either as a way of stopping the bleeding to allow the anesthetist resuscitation to take place and to allow someone senior to come, or it can also be a tool to use to make the suturing easier. If there are difficult tears, for example, there's an area which is bleeding excessively, put a tourniquet on and maybe the surgery can be done, and then it can be released to see whether control has been of hemostasis has been achieved. And how do we implement the new protocol? We have to bring all 3 categories of staff, the theatre nursing team, the anaesthetist and surgeon together, discuss and get consensus on the protocol, and train champions to spread the message out. So in summary, preventing near miss or death from PPH, the defensible approach. Implement the emotive approach to managing all women following vaginal birth. And at Caesar, we need to apply the same emotive principles of objective blood loss measurement in real time as the Caesar is progressing, having clear blood loss thresholds for the first response to PPH, and having standardized first response from the anesthetist and surgeon. And finally, the SASOG Better OBS guideline, as it is, I think it will benefit from maybe more incorporation of the emotive into standard management, because I think at the moment, what is there is more appropriate for refractory bleeding. In other words, bleeding that continues despite the first response, the emotive response. And I think I'll stop there. Thank you very much.
Great, Dr. Moran, thank you very, very, very much for a comprehensive talk. And I think it really did reach all the points that I was interested in and what we can do to improve the situation. So thank you very much. And I think we'll have to have a look at the guideline and see how we can update it a bit. So there were a couple of questions that came through. We're a little bit short of time, but the one that was of interest was just, should the PPH, I mean, I know you've said very clearly it's 500 mils, but what do you do if a patient already comes in compromised already with an anemia pre-existing? Should we be looking at a lower threshold, or is there something else we should do? Because we do get patients coming in like that.
Yeah, if a patient is very anemic before delivery and delivers, then obviously she may not need 500 mils of blood loss to go into circulatory collapse. So that patient will have to be managed with individualized care. But I think the point that we're trying to make is that up till now, nobody has been measuring the blood loss. And we never knew how much bleeding was coming out. So actually objectively measuring it, we find that far more people are bleeding 500 mils than we previously thought. And so, you know, we can talk about the threshold for people who are very anemic and so on, but just having that sort of background routine system of measuring the blood loss and responding to 500 mils will save a lot of people. Because even those patients who are already compromised, I mean, let's say it's an abruptio and they tend to have PPH anyway, you may find that no action was taken, you know, until well beyond 500 mils of blood loss, you know, before we were measuring it. So the measurement of the blood loss doesn't take away the need to still monitor the vital signs and to respond to those. Because of course, the blood may miss the tray or miss the drape and go on the floor. You can't just always rely on the what's in the drape, but it's just an extra layer of, let's say, security for the patient to be monitoring that amount of blood loss. And remember, we've got busy labor wards. A woman might deliver. The midwife takes the baby for resuscitation. The mother's alone. There's no one monitoring on an ongoing basis the blood loss. If she comes back 20 minutes later and is sitting on a bed with a few clots and so on, how would she know how much bleeding there's been? As long as she's on the drape or on the tray, she can actually realize whether there was excessive blood loss or not, which before she wouldn't have been able to.
So thanks, Dr. Moran. There are really a number of questions. I'm going to ask if you wouldn't mind having a look in the chat and maybe just typing an answer to some of them, because you are on the panel there. If you could just have a look at those questions. There's some really interesting ones. And one of them, which I think is important, is how to become an emotive champion. There's a midwife working in MOU. So I think there are definitely people who've listened to the talk today and who are very, very keen to be part of it. I'm going to let Dr. van Waart maybe just, I think we've missed most of our lunch break. I'm not sure if we're going to go straight to speaking to our sponsor, because I think Dr. Van der Waal's on at 12. Dr. Moran, thank you very much. Please will you answer those questions there in the chat?
I'll do that. Thanks.
Thanks, Neil. It was a wonderful talk. I think we'll definitely give it some good thought when we do the new guidelines. I think it is very important, and I think it's also applicable in private practice. I think we're going to take a short break now, a 10-minute break for everybody, just to get a cup of coffee before we start with the next talk. I think the talks, we've run a little bit out of time, but I think those talks are so important and relevant that I think everybody will forgive us if we run a few minutes late. So we're going to give you 10 minutes. Everybody just get a cup of coffee, and then we try to start at 5:12, and then we'll start with the sponsors talk straight away. So we see you guys all in 10 minutes from now. Thank you.